going to be speaking about genetics, and after the 3 talks that we had this morning, I don't think I will need to make much of a case for why genetics is important for SADS conditions. I will explain that I am a pediatrician. I work in the Division of Pediatric Cardiology at Primary Children's, but I also work in Intermountain Healthcare to coordinate genetic counseling and to oversee or kind of think about genetic testing as we're in this phase of very rapid change. I have no financial conflicts. You know, the scope of this problem, I don't think I need to reiterate. It's personal to most of you and has been covered quite well in the previous talks. But I do want to reiterate again that most of the conditions that we're talking about, these sudden arrhythmic death syndromes, are inherited or have a family component, or at least there is a large concern for that, whether they be the cardiac channelopathies or the cardiomyopathies and other structural disorders. And so when this occurs in a family or in an individual, there's going to be questions, and people are going to wonder, why did this happen? Is the rest of the family at risk? Is it going to happen to someone else? Can the condition be treated or the risk reduced? And we've heard some very exciting talks about future science and about the present medical management. And will there be anything else associated with this condition? And really, the answers to those questions really depend to a large extent on the genetic testing and whether a patient can be put into one of these risk categories or into a genetic category where we know something about the differences between patients. So the value of a genetic diagnosis can be summarized. They can confirm the diagnosis or provide an answer. So in a patient who already has a diagnosis for one of these conditions, we can figure out what gene is involved. It can guide treatment decisions, as we've heard this morning. It can add risk or prognostic information either to that patient or to people in their family sometimes. It can define the risk in those pre-symptomatic family members through testing. But I do want to just make sure we temper our excitement in this time of rapid acceleration of genetic technology, that there are potential harms to consider with testing. So there is psychosocial issues, there's guilt, there's anxiety during the testing and after, and there's issues of discrimination. And despite the laws that have been put in place to protect people, protect their health care from discrimination, unfortunately that protection does not extend to life insurance or disability insurance. There's also, as we're going to discuss, the risk of uncovering things that we don't know how to interpret. So incidental findings, uncertain findings, these can also contribute anxiety and uncertainty about the way forward for treatment. And then you don't turn on the news without hearing about the cost of health care. And I think the cost is well justified in these conditions, but I think we do want to just touch on that as we talk about who's going to pay for this. So I was given 2 topics to talk about today, or 2 titles, as it were. First is genetic testing, discovering the secrets of unexplained death through genes, and I'm going to back all the way up to the beginning since we have such a broad ranging audience here, and I'm going to talk about DNA, about genes, proteins, mutations, and some other terminology. And then I'm going to update us all on what is going on in the advancements of SADS genetics. And then finally, review what are the whys, hows, what comes back of genetic testing for arrhythmias. And then the other part of the talk was to be about genetic counseling and what is the role of family and detailed family pedigree. And I've put in a few case examples with pedigrees, and I hope that the value of genetic counseling, the value of family history will be clear through this talk, but it'll be kind of mixed in with the talk. So let's start all the way at the beginning. The DNA has been called the blueprint of life very aptly because it really does spell out the plans for our human body, our organism to function. So I really like this schematic where it shows the human organism, which is made up of trillions of cells. And each one of those cells, with a few examples, contains a small nucleus. About 10% of the volume of that cell is the nucleus, which is kind of packed with a polymer of nucleotides called deoxyribonucleic acid, or you all know as DNA. And there's actually quite a bit of that in a human. If you were to take all the DNA, this polymer, and stretch it out from a single cell, it would be about 6 feet long. And if you took it all from a whole organism and stretched it out, you could go to the sun and back about 70 times. I've seen different figures, but we have a tremendous amount of DNA, a length of DNA in our bodies. It's quite small, so it can be packed down to that tiny little 10% in the center of the cell. And we actually have 2 copies of our blueprint. So nature was wise in providing us with a backup. 1 copy we get from our mother, 1 from our father. And these are organized into distinct pieces of DNA called chromosomes. So here's a chromosome pair. They are identical in the content of genes and so forth, but they're not identical in the actual spelling or base pairs of the genes there. There's going to be variants that differentiate those 2 chromosomes. So that's DNA. And DNA doesn't really do much of the work in our cell. In fact, it doesn't really do any of the work. It's part of what we call the central dogma of biology, where things get done, and it's the blueprint, and through replication it's copied and passed from cell to cell, so all the cells have this blueprint and they know what to do. But the real work is done in small part by RNA, but the main molecular machines in a cell are called proteins. And their spelling of these proteins are encoded on the DNA in packets called genes. So those genes are read into a messenger called RNA that transfers it, and then it's read into a protein. So proteins aren't passed from cell to cell. They're made in each cell based on the spelling of the DNA. And as you all know, the DNA is basically A's, C's, T's, and G's aligned in a pattern. And this is the way information is passed in all organisms, with a few exceptions on the planet. But this replication process is not perfect, and we've heard about this quite a bit today, that DNA is mutable, mutations accrue. Someone asked a question about new mutations and if there was any chance that something that had happened to them could have caused a new mutation, and it turns out now that we can look at whole genomes that we know that about 50 times when a new human is produced, that there's 50 new mutations that are very deleterious just in that not deleterious, that are new in that patient or that person. So mutation is actually fairly common. And it's actually important for evolution. That's how evolution is based. Mutations in genes, they can either eliminate or alter the function of proteins. If a mutation happens in one of those coding elements, they can disrupt this information flow, and the molecular machine that's made is either imperfect or not made at all. But we have a backup copy, and for a lot of genes, that will suffice, or at least for some function. I just need you to remember that we do have those 2 copies, and most of the mutations we'll talk about today will be in just 1/2 of the proteins that are produced. So here's a slide that I added because I think it's worth backing up a little bit and doing this slowly. And this also comes from a really nice review of this topic by Dr. Tester and Ackerman that was already mentioned this morning. But here's the spelling of a gene here, A, C, T's, and G's. And if you divide those into 3-letter packets, these are called codons, and each one can be read into an amino acid to form a polypeptide. So here's a series of these polypeptides being read and turned into a protein. There are 3 types of mutations shown on this slide, or variants. So a variant at the end of this codon doesn't actually do anything because the spelling for this serine can either be TCG or TCA, doesn't matter. However, if you change the first T to a C, you get a proline. So that would be a missense mutation or a change in the protein spelling. And if you get this middle one changed to an A, that's actually the spelling for a stop codon, and the protein synthesis would stop. So this is a nonsense mutation, or mutation that kills the protein. There's some other terms here that I've put on the side that, thinking through this talk, if you really want to understand genetic testing, you'd have to understand, and we don't have time to go through every one, but I think quickly some of the ones that have been mentioned today, polymorphisms, any variant in the sequence could be called a polymorphism, but we tend to refer to variants that are fairly common and we don't ascribe a function to, whereas mutations, we would tend to say those are rare changes, not seen in a lot of individuals, and tend to have some functional significance, like a missense or a nonsense. Okay? Also, heterozygous, this refers to having 2 copies of this gene, and if you have a mutation in just one of those, you're heterozygous. If it's in both, you're homozygous. We're going to talk a little bit about phenotype, penetrance, and expressivity as we go along, and I think those have been talked about this morning. And then sometimes DNA is not just substituted with other nucleotides. Sometimes it's either missing or there's some extra DNA added during this replication process. So again, a normal strand up here, if you had an extra nucleotide inserted here, you would change the frame. So remember I said you had to read this out in 3 nucleotide packets. If you add an extra nucleotide, you change all the subsequent reading frame. And that usually leads to a stop codon down here somewhere and the protein is killed, but it also adds some nonsensical or sometimes harmful proteins after that, did I say insertion? Either way, insertion or deletion there would change the frame. And then if there's a deletion or insertion of 3 nucleotides, then you can keep the same frame and the rest of the protein would be made, but you would have this extra amino acid here. And that could or may not have functional significance. So the real workhorses, the real heavy lifters in the cardiac myocytes for this electrical conduction are the channels, and we've heard a lot about the channels. We know a lot about the genes as well, but just to reiterate, these are proteins, not genes. The genes read these out as proteins. Most of the channels have multiple transmembrane portions, extracellular portions, intracellular portions that we'll cover a little bit. And then to reiterate, nonsense mutations would just eliminate half of the proteins produced. Missense mutations would actually change half of the proteins into some new form. We know a lot about the genes that cause long QT. We can actually account for about 80% of cases. If we examine them genetically, we can find a change. You all know that the 3 up here, 1, 2, and 3, are by far the most common. And now, through some advances in technology, we can test for these in mass or in panels of genes. So let me just back up a little bit and talk about next generation sequencing. So we've gone through DNA, what it is, what it does, how does it turn into proteins. Now we're going to talk about how do we read that DNA sequence to decide if someone has a mutation or a variant of some other kind. So just a historical view of this, back in the early 2000s, around 2000, 2001, when we completed the first human genome, it's still quite expensive to sequence DNA, and if we'd have turned around that day and done another genome sequence, it would have cost us about $100 million. The project to get the first sequence cost about $3 billion. But over the last 10 years now, we've had this incredible plummeting of the cost of DNA sequencing. This blue line here is actually the rate at which computer power tends to progress. And that doubles every 2 years or so. The cost of DNA sequencing has eclipsed that rate of sequence. We all have our new smartphones and our new computers, and we think that's progressed fast. The rate at which DNA sequencing technology has progressed has really been astounding. And not only has that the cost dropped, but our ability to sequence DNA, how much we can sequence per day, has increased dramatically as well. So today, on one of the many platforms for sequencing, it costs between $5,000 and $1,000 to do the whole genome, and it can now be accomplished in a day, or 27 hours, or 8 hours, depending on the platform. So what used to take many years and then weeks now takes a mere days and can be done for really the $1,000 genome, which was the goal of many, has been met. And we're already on to the next generation of sequencing. And really, we don't know exactly what tomorrow will bring, but there's prototype devices even now that could bring a $100 genome into view, and perhaps less. And this could actually be done in a person's home. And so some people would raise their hands and say the future is now. The promise of less costly and more expansive testing can be realized. And I think that's true to an extent, but I think there's multiple cautions and caveats that needed to be added to this statement. So as we go through the rest of this talk, I want to just make sure we're aware that there are harms to the sequencing, that our ability to interpret this massive amount of data that would come off has not progressed at quite the rate that the ability to obtain the data has. And this could cause some real challenges to our healthcare industry. But for long QT, for channelopathies and other SADS conditions, this has been very good news. Where we were only able to test just for a few genes for thousands of dollars, now we can test for all of the long QT genes and add new ones as they come along for about the same price. And this is not recommended to be done as a shotgun approach. We don't test for all of these genes in one big throw. We use the cardiologist's expertise to narrow down the phenotype as much as possible and only test for that group. And in some cases, we'd only be testing for one gene because the phenotype is so clear. Similar panels of tests are available for cardiomyopathies that we've heard about today. And really, I kind of tongue-in-cheek called this a genetics arm race because every time we turn around, there's a new panel of the next best genes. And arguments can be made for this. For example, in a postmortem molecular autopsy, as it were, for sudden cardiac death, it might not be easy to narrow down just which group of genes you would want to sequence. So they've added a mixture of the most common SADS genes for that case. And then for cardiomyopathies, where there's just so many genes and some cause hypertrophic or dilated or both, paneling those has also seemed to make some sense. It's progressing, though, and now we have a 79-gene pan-cardio panel, which is a mixture of cardiomyopathies, channels, structural heart defects. And I think this is just going to continue on and on as this sequencing is more and more easy to do. So I want to just cover these 4 questions mainly here. I want to keep in the back of our minds that we need to be cautious, but it is exciting, and we're able to accomplish much more than we had in the past. But who should have testing? What is the process? Who pays for it? And what types of results will be returned? So most of the conditions we'll be talking about are autosomal dominant. That means they're not on the sex chromosomes. They don't affect men and women differently from a genetic standpoint. They're located on one of the 22 autosomes. And it takes just one mutation to cause the disease in general. They're dominant. That's usually from an affected parent to one of their children. They always draw this as 4 people and 2 of them are affected, as if once you've gotten those 2 affected, you won't have any more children with it. But we need to emphasize with each child, there's a 50-50 chance of passing this on, and you might have 4 affected children or none. About 5 to 10% of the time, this happens as a sporadic, it's not a familial mutation. So we always want to emphasize that testing needs to happen in an affected individual, and not just an affected, the most affected person in the family if possible. We'll talk a little bit about what happens if you test unaffected individuals. And then this can be followed if a mutation is found with predictive testing in asymptomatic relatives. We brought up, and this morning the discussion about reduced penetrance was brought up. Penetrance refers to whether someone who carries the mutation actually manifests the disease. So the percentage of people in this family that have the mutation who actually have the symptom. And then expressivity is a little bit different. It refers to you have the disease, but it's not as severe as someone else in your family. So there is both reduced penetrance and variable expressivity are the rule in most of these conditions. So the recommendations for long QT testing are here taken from the guideline. It's fairly straightforward. In index patients, whether they have the diagnosis for long QT or whether it's suspected long QT, testing is recommended. Not only to make the diagnosis, but as you've heard over and over this morning, but it can definitely change how we treat people. So stratifying them by gene is important. Can also be considered in individuals who are asymptomatic but have more borderline QTc measurements. And then in long QT, once a mutation is found, testing in family members is recommended. If we step back and look at some of the more common arrhythmic conditions, indications for those, here again is the long QT. It's recommended in index patients, family testing, and then in some other scenarios. All of these conditions are valuable for making the diagnosis or confirming the diagnosis in an index case and for family predictive testing. None of them are currently being used for universal screening or pre-sports participation. And this will be discussed in a minute, but I will emphasize that because of the number of variants that we would find and our lack of ability to interpret those would make this very difficult to do at this point without some kind of pre-screening. And we can definitely have discussions of that in the panel. So here's a first case. This should be pretty straightforward. A mother brings her 2-year-old son to the cardiologist. It turns out that the patient's father had recently been diagnosed with dilated cardiomyopathy and that there was a positive family history in the patient's father's brother or the uncle. And she's requesting that the boy have genetic testing for dilated cardiomyopathy. So based on what we've said, any of you could do the counseling at this point and say, we would not test the boy, he's pre-symptomatic, unaffected, and the real person who should be tested would be the affected father. And he was in fact tested, and a deleterious mutation was found in SCN5A. The son actually turned out to be negative, and this is the main point for this slide is that if we had tested the boy and he was negative, because genetic testing is not perfect, we would not know whether he really had a dilated cardiomyopathy gene or not. But in testing the father and finding the gene and then testing the son, we can actually rule it out. And then we can go forward and also look at other individuals in the family, including pre-symptomatic individuals. And finally, because we know the gene, based on some of the discussion we've had this morning, there may be different treatments in this family than there would have otherwise been. What is the process? Well, we feel like genetic testing should always involve a cardiologist with specialized training in these conditions and a genetic counselor with specific expertise. That isn't always possible, but that would be my recommendation at least. And this should include, besides the rest of the workup, a complete family history. And then if indications are met, most of these tests, especially the large panels, require blood draws, but some of the confirmatory tests work on saliva samples. Turnaround's around 8 weeks. And we also recommend a face-to-face post-test genetic counseling because of some of the complexities that will result. So who pays for this? It's approximately $3,000 to $5,000 for these panels. Confirmatory tests are less, depending on the lab and payer. And for long QT, for example, insurance has come around, seen the utility, and it's generally well covered. Medicaid, Medicare are a little bit different, and I think that's based on contracts. Most of the companies that do these panels have CAP programs, financial assistance for patients who are unable to afford this or don't have insurance. But still, as I mentioned before, the costs of healthcare being what they are, we prefer that testing be used judiciously, that the appropriate people be tested, followed by confirmatory testing, that we try and reduce the amount of shotgun screenings. And then the question comes up, isn't this going to get cheaper and cheaper? And if we have a $100 genome, then couldn't we do screening then? I think there's a few roadblocks in that. I already mentioned the sort of delay in our ability to interpret the genome that we're being handed, but also there are some issues around patents of genes. Some of the long QT genes and some of the genes for hypertrophic cardiomyopathy are patented, so different companies have to pay royalties. And I won't open that can of worms any further, but I think that there is some concern that we may not be continuing to fall at quite the rapid pace that we were. Again, another panel discussion perhaps. So what will be returned when you get one of these tests? Well, in a simplistic way, we could say it will either be positive, negative, or we won't be able to interpret it, and that is true. A positive result, we could say, would confirm the diagnosis and allow predictive testing. A negative result for one of these tests, it depends on who the test was done in. In an affected individual, we can't rule out the presence of one of these conditions because testing is not perfect, and the sensitivity or the percentage at which the disorder is detected will differ, and it's not perfect for any of them. However, if a mutation is already known in the family and an individual tests negative, then one of their relatives, then that is predictive. And finally, variants of unknown significance. These are a big problem, and many of you in this room may have already experienced having a variant of unknown significance as a result. It turns out that, at least for long QT, it's quite common to have variants in this gene. If we took this is a study that actually did take a large group of individuals and look at their genes, and they actually found 4 to 8% of healthy controls had a positive test in that the test showed a rare change in the protein that could be interpreted out of context as a mutation, but is probably just a meaningless polymorphism or a modifier. So the take-home message from this is the result you get from a test is highly dependent on the patient you do the testing in. So we want to test the affected and, in fact, the most severely affected patients because those give the clearest, most interpretable results. Another way to divide this up, especially now that we're doing gene panels, you're virtually certain of having some variance resulted. If you do this many genes in a test, you will receive variance. So maybe more productive is to divide those variants into different classes based on whether they're deleterious, of unknown significance, or benign. So the benign variants would be ones that we see in many individuals, not predicted to cause an effect. The deleterious ones would be only present in other known affecteds, not in controls, and have strong evidence of effect. And then we have those problematic VUSs where they're absent in other affecteds, they're absent in controls, so they're rare, but their effect is unclear. For the deleterious variants, they kind of allow us to do the testing in first-degree relatives that we would like. For the variants of unknown significance, it's a little more tricky. And I think the recommendation to do testing in affected relatives is based on the fact that you might be able to clarify a variant of unknown significance if tested in multiple affected individuals. If some of them test negative for it, then it's not segregating with the disorder and is unlikely to be important. But in these cases, we definitely recommend genetic counseling to help interpret those results. So we don't have to spend as much time as I thought we might on this because we've talked about this in really good detail. But to clarify, you'll hear about a genotype-phenotype correlation. And you've already heard a lot about that, and maybe you didn't know it. But a phenotype is the manifestation of a genotype or a variant or a mutation. So what is read out when that variant occurs in a protein is your phenotype. So deleterious mutations in one of these channels, the phenotype is long QT syndrome, for example. When we say genotype-phenotype correlation, it's whether there's an ability to predict from someone's genetic test what their phenotype or their disease will look like. And we've heard over and over today that there's knowing which gene is affected for a particular disorder does have especially for long QT, a good genotype-phenotype correlation. We've heard about some of the trigger events that are common from 1, 2, and 3. We've also heard about some of the treatments that vary. And it's actually, you've heard this morning that not just knowing which gene is affected, but where in that gene the mutation is, or where the protein is disrupted also provides information as well. So this is a fairly recent paper. Again, this is one of these channels, and you know that the protein is sort of passes in and out of the cell membrane, kind of like a needlepoint string that's in and out. And in the transmembrane domains, you see there's been quite a few mutations for long QT1. And then in these extracellular domains, particularly these intracellular loop domains, there's been some mutations found. And these have turned out to be the highest risk for phenotypes in long QT1 syndrome. They have the highest presenting QTCs. They have the highest rate of cardiac events. These are these missense loops versus the others. You've seen quite a few of these figures today. And then I think quite interesting, they also show a different response to beta blockers than the others. This is actually, in the positive though, this is untreated and this is treated. And there seems to be a bit better response, or quite a bit better response perhaps, to beta blockers for patients who have mutations in these C loops. And you've also heard about a similar story for long QT2, except for now the most deleterious mutations happen in this pore region. And you also heard a bit of a similar story for SCN5A for long QT3 in Brugada. This is a table that kind of shows utility for genetic testing, and I think of that partly as whether there's not only is there predictive diagnostic value, but is there any genotype-phenotype correlation that will help you change what you do for the patients. You see that really only for long QT is there strong benefit in all three areas of this, that the others have some prognostic input, but very few cases where there's actual therapeutic yet, although some of the talks this morning hinted at some of that. And then I also put over here what the yield of this testing is. So long QT syndrome testing is not perfect. About 20% of the time we won't find a mutation. For the others, it drops down even lower. So we need to keep these in mind as we get negative results back. Okay, so I'll move on to genetic counseling. Again, I help organize genetic counseling in Intermountain, and I'm somewhat biased, but I think genetic counseling is incredibly important in the field of genetics, and especially in the arrhythmia clinic. I think it's only going to get more complicated. Doctors are only going to get more busy, and this is going to be harder to do without counselors. They're able to provide these detailed pedigrees and provide personalized risk assessment, explain the risks and benefits as well as the costs and limitations of testing, and then manage the ever-changing complexity of ordering these tests and as they change. We are quite aware and are paranoid a little bit about lost to follow-up tests that either don't get read out appropriately or it's a variant of unknown significance that later is changed, and that follow-up needs to be ensured, and we see counselors as being crucial for that. And then they also can play a role in communicating with the at-risk family members about possible pre-symptomatic testing. This is a figure that I like that kind of shows this in a different way, that shows the various events, things that are happening to patients who have one of these events or diagnoses, and kind of relates the different areas where genetic counselors can provide support and aid. And it brings into it a little more of the psychosocial benefits of this. Also, it's been brought up that genetic testing is not perfect, and we want to make sure that this field moves forward and that patients who have these tests and are negative are plugged in appropriately to research so that we can continue to expand our knowledge. And genetic testing is complicated and hard, and in fact, it's often messed up. So we have a national lab here in town called ARUP, and they did a study on error in 2010, and they found that of all the tests that came in during, I think, 6 or 7 month period, if I'm not mistaken, that 30% of the orders for complex gene tests were mistaken. They were either, that clinicians either ordered the wrong test or ordered the wrong mutation for a confirmatory test, and that they have counselors on the line to help correct these. But I think it just underscores the need for genetic counseling and really well-informed physicians in a field like this. And I wanted to just mention there are several excellent companies nationwide who are providing genetic counseling services by telemedicine. And we've investigated using some of these services here in Intermountain because they're really quite good. So for areas where they have cardiologists but haven't been able to utilize counselors, that's another option. So I'm going to close with just another another case presentation that I think illustrates some of these points. So this is an infant, and it's very similar to the case that Dr. Bunch presented earlier, but I've been assured that it's not the same case. That this is a family with long QT1 where an infant presented with a much more severe form of the disorder, a much more markedly prolonged QTC, and was having spells concerning for arrhythmia. The patient did end up having the familial mutation in KCNQ1, and her two brothers did as well. However, the cardiologist, I think astutely, because of this really different presentation, much more severe, despite what I've just told you about different expressivity in families, went ahead and did the panel as well and found that this patient also had a mutation in KCNE1 that would be suggestive of long QT5. And this was actually inherited from the father, who was asymptomatic and adopted, so didn't have a family history that would have suggested this. Further testing went on to show that the older sister had the mutation as well. So I think this helps illustrate just how hard genetic testing can be. First of all, making sure you're ordering the right tests, interpreting those tests, and then just being able to discuss those with the family in a meaningful way. This actually went on to change treatment for this patient who was put on a beta blocker. So a few take-home messages. These conditions are heritable. I think I'm really preaching to the choir on that. Rapid advancing technology now allow expanded, more sensitive genetic testing and screening. And this is still in fairly rapid flux. Next generation sequencing is now next generation sequencing, and I think the complexities here are going to increase as well. Once you do have a patient's molecular diagnosis in hand, it can inform prognosis, risk assessment, and treatment. That's an obvious take-home from today in this very exciting meeting. But significant complexities are going to be encountered in interpreting these tests. And the more genes we test, the more variants we will get back that we don't know what to do with, and there's going to be some challenges there. I think it's important just to reiterate that physicians who take care of these patients really need to have some specialized trainings and to work closely with genetic counselors in this process. And with that, I think I'm done.